Hello and welcome to everyone. I just want to take a quick moment to thank you all for joining our injury prevention webinar today. My name is Sawyer Barkus. I'm a product marketing specialist with ChiroTouch, and I'm so excited to be here today. I want to extend an extra warm welcome to Dr. Maggs, developer of the Structural Management Program, which is a leading sports biomechanics program. Dr. Maggs has specialized in sports biomechanics for over 45 years. Dr. Maggs is also the developer of the structural fingerprint exam and the proud founder of the Concerned Parents of Young Athletes program, which is the leading injury prevention program for middle and high school athletes. And with that being said, I'm going to go ahead and pass things over to Dr. Maggs.
Thank you, Sawyer. Thank you immensely, and welcome everybody. First of all, a big thank you to ChiroTouch for sponsoring this webinar today. We've had them in our office now for probably 3 to 4 years, and we continue to expand their involvement in our office. And I can't imagine a better partner. The program we're going to go through today, I'd like to think is an advanced program, and I'd like to think that everybody kind of agrees with that, because we've gone out there into the marketplace to find out, what do people want, what do they need. And the truth of the matter is, we are currently in a scenario at this stage of the game that is really kind of broken. The healthcare system is really kind of broken. And what's happened is now a lot of the profession has migrated towards the palliative care, because that's what insurance covers. But the public is seeking more. And with all of the bio wearables that are out there, they're kind of data driven, and they're willing to pay for it out of pocket, because people have never been more interested in having a better quality of life and a longer life. And we see that in many, many different ways in our society. However, in musculoskeletal, it's kind of dragged behind many of the other industries. And so therefore, I'd like to think that you'll agree that this is one of the leading programs that has ever been designed in musculoskeletal. So we've got a lot of slides. I'm going to be very efficient. I'm going to talk rather quickly. Any questions you have, I'm more than happy at any point in the future to discuss with you. Any disagreements you have, that's okay. We're chiropractors, we're supposed to disagree. But I want to get started. I want to give a little background of myself so you can kind of understand how I got to where I am today. Back in the mid-90s, I had the tremendous opportunity to work with the New York Giants and with the Chicago Bulls. And I worked with the New York Giants. I worked for 4 years. Every Monday, I went down to the stadium. I worked in the strength department. With Chicago Bulls, I consulted with them, and we went into the locker room many times consulting with their strength department. But the experience I got was second to none, and I realized how reactive all of their musculoskeletal care was. I also had a running column, a national running column, a sports medicine column in magazines throughout the country, 2 of them here, Florida Running and Triathlon and New England Runner. And what it did, it gave me an opportunity to get emails galore with all of the questions that athletes have. So between those 2 experiences, I really feel like I had a front row seat on understanding society and what problems they had. And many of the problems were being dealt with by reactive doctors and reactive therapists. So at that time, that was the inauguration of structural management. I said, there's got to be a better way. I mean, you take a car into a dealer and they, look at the barcode on it. You've got the history of the car, you know what maintenance needs to be done, and you drive out feeling good about your car. That does not exist with the human body, the most valuable asset that any human has. So 30 years ago, I started the development of the structural management program, and the whole mission was to create proactive versus reactive. Now, if chiropractors can maybe not be ego-based, which many of us are, and I'm probably one of them. If we can, maybe have a question mark rather than an exclamation point in our mind, we are the perfect profession to lead this musculoskeletal industry into a proactive, preventive product. And no one is allowed to do as much under our scope of practice, diagnostically or therapeutically, yet many of us do not use those benefits. And I have taken advantage of all of those benefits. The questions that were asked on the survey today, I believe, are key technologies that chiropractors should incorporate into their practice. And to the level that anyone listening is interested in it, we've already created the program, and you have the opportunity to join the mission and to bring a higher level of technology and prevention and proactive care to your community. In the past 5 years, we've published 8 peer-review research studies in a medical journal. And these studies all have to do with the human body, and it's information that has never been published before. So it's all on the website, drtimmaggs.com, and we're going to be highlighting a couple of these studies today. I've spent my entire life examining patients. I've examined tens of thousands of patients. We've x-rayed every one of them, biomechanical x-rays. We did digital laser foot scans on thousands and thousands of patients. So we've collected an enormous amount of data. The conclusion is that everyone has a structural fingerprint. So you can lay this structure down and you can adjust it and have them stand back up and walk out. But the biomechanical faults that they came in with are very likely going to be the same ones they leave with. And is there more that can be done? And that's what this talk is about. Structural fingerprint, we are all 100% unique. These are but a few of the variables that create who we are. And I've created the tests on how to detect the critical information from this picture, how to interpret it, how to communicate it to the patient, and what to do to improve the overall symmetry of the body and the body weight distribution. Because those are two characteristics that if all of us did that with every patient, we would probably change the face of healthcare in this country. In 2012, I published my second book, Fixing the Healthcare Crisis. And the theme of the book was that to fix the healthcare crisis in this country, we have to start by fixing musculoskeletal. Musculoskeletal is a reactive industry, so we wait for people to break and then work to get rid of the pain, but we don't do anything to preserve the human structure. And if you can't move, all of the other degenerative diseases are going to accelerate rapidly, and that's where our country is at. So you have a lot of musculoskeletally disabled people at the age of 50 who say, I used to do this, but now I don't. And that's become acceptable. Well, I say that has to change, and we are the profession to change it. So if you look at this picture here, you'll see there are areas of that picture that are inherently under more stress. And now when you throw repetitive activity or traumas into that structure, there's going to be loading issues. And when the loading of a tissue exceeds the capacity of that tissue, compensatory physiological changes occur. These changes begin occurring pre-symptoms. So when you talk a heel spur, when you talk a bunion, when you talk disc injury, those changes are occurring long before symptoms come on. So that led to the structural fingerprint exam, which now I've done tens of thousands of these exams, and it only furthers my opinion that everyone has a structural fingerprint. Everyone is 100% unique. If you question that, go to a road race where people are running and go to the finish line and see if you can find any two gaits that are even remotely similar, because that really shows the difference. You know, you have static imbalances, but when you put that body in motion, it becomes totally unique as to how that person moves. Okay, so let's close the door on that chapter. I want to start a new chapter here because this was a case that truly changed my life. And again, I've been in practice 47 years, so I don't have many cases that have done that. I think I was one of the only chiropractors to have an office in a school. And I would do our structural fingerprint exam on these students at no cost. And then I would have an office in the school, and they were able to come in once a week to get treatment. I made parents realize your sons have biomechanical imbalances, and they really grasped the concept, sent their kids in, went through exams, x-rays. I took this x-ray barefoot, excuse me, and you can see right femoral head is 4.3 millimeters higher than the left femoral head. We did a scan of his feet. He required orthotics, and we put orthotics in his shoes, and we let him go because that's what we did. Immediately, he started experiencing pain. So every week when he would come in to see me, he would continue to complain about the pain. It wasn't until October, when summer was over, I finally got back to my office to re-x-ray him. And with his orthotics on, I re-x-rayed him, and he went to 6 millimeters. In addition, he developed a stress fracture. So needless to say, this rocked me because I don't have people get worse under my care for the most part. And I had never seen a femoral head height difference worsen. I didn't know that was possible. No one had ever suggested it, and I've searched, and I've never found anyone who has ever done research to prove that that's a possibility. So we put a 5 millimeter lift under his left orthotic. We started lasering his pelvis, and he healed within 2 to 3 weeks. It was incredible. But from that day forward, I changed my policies. Over the next 3 years, we created a new procedure. We now call it Dr. Mag's leg length test. And what we do is we take one of our x-rays is an APLS. We take it barefoot with digital technology. You quickly measure femoral head height. 3 millimeters and below is normal. Once we take this x-ray, we then put orthotics in the shoes, and then we retake that x-ray and measure in what femoral head height is. Now, the first paper we did was 351 patients, and it was published in Orthopedics and Rheumatology Open Access Journal. You don't have to look for the journal. All of the studies are on my website. But my co-authors, who I am so proud to have been associated with, Dr. Alex Ciozos, who's an orthopedic surgeon, specializes in hip replacements, Dr. Stephen Brownstein, a medical radiologist out of New York. And the assumption in my head and the assumption in the industry was that orthotics leveled femoral head heights. So these are two pictures that I created in 2006, and it kind of reinstilled in me, put orthotics on and everything balances out. But I've learned nothing could be further from the truth. So here we have 5 biomechanically imbalanced structures, and I've learned that every human is one of these 5. And everyone who comes into your office and gets adjusted and stands up and walks out remains the same imbalanced structure. There's a temporary benefit from the adjustment or a temporary benefit from a physical therapy treatment. But unless you address the collapse of the feet, unless you address the femoral head height difference, then you're not changing the underlying cause of the problem. I'm going to go through in more detail the difference between these 5 a little further down the road. 2011, I had been lecturing for 3 years with Dr. Terry Yoakum. He had listened to me so many times. He said, let's write an article. 100% of my patients get custom orthotics. What about yours? He said, because I really understand now why you say that. So in 2011, I was committed to that belief, but I didn't have the data to support it. But I'd seen so many patients, and that was part of our policy to put them in orthotics. So the 5th research paper was 1,001 scans of patients' feet over a 3-year period. And what you can see is that to the far left is the optimal foot, to the far right is the total collapse, and in everything in between. 100% of these patients aged 8 to 83 had collapse of the feet. 10% were moderate, 90% were severe in total. Secondly, the collapse increased with time. So those patients were starting in my office with collapse, and we saw that the collapse continued to worsen as time goes on. That's why people's feet grow as they get older. So at what point do you address that? So now here's how the thinking goes when you talk custom orthotics versus over-the-counter orthotics. If all you do is look at the feet, which, many chiropractors, all podiatrists, the Good Feet store, any orthotic company out there, they look at the feet and they compare their orthotic to the next orthotic, and everybody's got a better orthotic. For 20 years, I traveled the country teaching about biomechanics, and one of the key elements we taught about was an increased Q angle. So again, custom orthotics or over-the-counter. You might think, well, custom, the 2 feet are different. You have to have custom. However, what I've learned is that the most important measurement in the human body is femoral head height, because if it's unlevel, then the weight distribution in the lower extremities is imbalanced. And if it's unlevel, the spine is sitting on an unlevel foundation, and therefore chaos is the future. Okay, so what we realized through our study was that we don't want custom orthotics. We want a high quality over-the-counter orthotic, which now makes them more available to people, because I've sold thousands of orthotics, custom orthotics in my life, and the number one resistance is the cost. So now if you can dramatically reduce the cost and educate people as to the importance of the orthotics, and our 5th paper does that, then what you want in the feet is symmetry. You don't want difference. You want symmetry of the feet. But then you have to retake that x-ray of the femoral heads to determine, is it more than 3 millimeters off? If you don't x-ray at all, then all you have to do is start with orthotics on each patient and send out for an AP and a lateral, because nobody will want to take just that AP. But if you have your own x-ray system, you can get away just taking that AP as part of your, orthotic program, and that will tell you if it's more than 3 millimeters. If it's more than 3 millimeters, then we need a lift. So what I did in the process is I developed high quality over-the-counter orthotics, because I could not find any quality over-the-counter orthotics that matched the quality that I was used to. So we created our own line of over-the-counter orthotics that we now make available to the public. So, new study. People will ask, how many people have difference in femoral head height? Between April 1st and July 31st, 4 months in 2024, 100 of our new patients with new orthotics, we took the AP LS X-ray. The normal femoral head height difference was 3 millimeters and below. So 21 were normal, which meant 79 were abnormal. So this is a real study. There's a lot of theories out there, a lot of opinions out there. This is a true study. Once you put orthotics in the shoes, take the x-ray, and what do you see? So 79 were above 3 millimeters, which means a lift should be considered. 53 were above 5 millimeters. That means over half of the patients were above 5 millimeters. 24 were above 10 millimeters. 7 were above 15 millimeters. 3 were above 20 millimeters. And 1 was above 30 millimeters. Which my purpose in showing this is just to magnify the importance of looking at femoral head height, because again, after 47 years, my conclusion is it's the most important measurement in the body. The goal is to fix the feet, symmetry and support, and level the femoral heads. Once you do that, your clinical outcomes are hugely, hugely better. Just to show what the industry is doing, a research study for biomechanics before and after hip replacement. Even when you have a hip replacement, which is typically caused by the abnormal loading, Don't tell me the other hip didn't do as many steps as the replaced hip. But you can see 23.5 millimeters off. And with duals, it's 20.6. So we've had many, many patients with hip replacements, knee replacements. The industry does not look at femoral head height. So that is a huge market for you if you have a patient going into joint replacement, or if you have patients with joint replacement. You want to get orthotics in their shoes and take that x-ray, get that x-ray taken, and get the lifts put in to try to balance that weight distribution as much as possible. Okay, so now it gets good. Close the door on that chapter, if you will. We're starting a whole new chapter. I'm in the sports world. I've worked with the New York Giants, the Chicago Bulls, many colleges, many high schools. The overwhelming fact is a chiropractor has no authority in the locker room. So even if I think the structural fingerprint exam is the one that should be done on everyone in the New York Giants locker room, I have no shot of doing that. In my community, Albany, New York, I live a little outside Albany. The Albany Patroons are the most storied minor league professional team in history. Phil Jackson, who has won more NBA championships than any coach in history, he won his first professional basketball championship coaching the Albany Patroons back in the 1980s. And now many, many coaches and players who have made the NBA have gone through the Albany Patroon organization. In 2020, I took over as owner for the Albany Patroons because here I am at the press conference and I said to the media, I said, our current sports medicine system is inadequate, ineffective, reactive, and they are the cause of the problem. And I'm going to prove that my structural management program is superior to theirs because we're going to collect the data and I'm going to prove it. So, man makes plans and God laughs. We know that there's over $1 billion spent in the three major leagues in this country, over $1 billion. And many of you who are sports fans suffer through the injuries that all of our key athletes have at critical times of the year. And just remember, they're all reactively cared for. So back in 2020, COVID hit. We played 9 games, but we had no injuries. And I had an article published in American Chiropractor telling the story. So even though we had no injuries, it wasn't the results that I wanted. So when these players came into camp, we examined them, x-rayed them, got them into orthotics, took another x-ray, put lifts on where needed, treated them twice a week, 9 games, no injuries. So now, fast forward another 3 years, because 2020 season was eliminated. 21 season was eliminated. In 22, we had a new coach who came in because I was no longer the owner. A new coach came in. He was a Division I coach to a local university. So he had a relationship with all of the orthopedists in the area. And he wanted to use them instead of our system. So although I was the team doc, I would only get players after they were injured. I didn't get to put them through the examination the same way. We had the most injured plagued season anyone could imagine. We lost players. We had players who needed MRIs, couldn't get them MRIs. It was just a highly stressful, typical year for an organization when they reactively care for their athletes. But in 23, the coach that had been there in 2020 came back, and now we incorporate the whole new system again. Players come into camp, we examine them, x-ray them, and do all that we do, treat them twice a week for 4 months, and we collected, on Research Study 6, we collected all the data, 11 players. So here's what we have. Every player was in severe or total collapse. So obviously orthotics were needed. And then we put, for those, which I think were all of them, were over 3 millimeters, or maybe one wasn't. But if they were, we put appropriate lifts in their shoes. We then x-rayed them before and after the orthotics. We got them all orthotics, obviously. We put lifts on their orthotics. Now here we can see this is Crooked Man 1. And Crooked Man 1 means barefoot, 12.5, with orthotics, 4.8, we put a 3 millimeter lift under his left orthotic. Crooked Man 2, which I learned is shocking, 12.6 barefoot, 13.9 with orthotics. We put a 7 millimeter lift under his right orthotic because that's the maximum height that you can put under there. However, keep in mind, 22% of the patients in that 351 patient study, 22% had their femoral head heights worsen when you put orthotics in the shoes. Crooked Man 3 was level when barefoot and above level when we put orthotics on. Crooked Man 4 was level on both. And Crooked Man 5, you can see 29.2 millimeters. And where it's abnormal on the barefoot, it stays abnormal with orthotics within 1 millimeter. So that's Crooked Man 5. And this fella's 6'9", and you can see he has almost a 30 millimeter difference in femoral head height. So they came in twice a week. We lasered, we spinal decompression every time. And for 4 months, twice a week, we treated them. Here we are on the cover of American Chiropractor. This, coincidentally, for any of you who know former NBA players, this is Manute Bol's nephew. Manute Bol was, I think, about 7'7", unique individual. So here are the results. 2023 season, 32 games, 11 players, 1 player missed 2 games with injury, unprecedented numbers. And I'm saying if we turn the dial up, if we get proactive, if we start using orthotics, take the x-ray, use lifts when needed, start using chiropractic care with the other technologies proactively, not just reactively, we are the answer for this entire sports world. We've also brought this program to the middle and high school market because the concerned parents of young athletes, my whole mission is that we start at the age of 12 with the structural fingerprint exam and get teams bringing their entire team into our offices, going through these exams, getting the orthotics in the shoes, setting up treatment programs for the entire season. Because currently this age group, their sports exam consists of eyes, ears, nose, and throat. So never before has anything been so missing in an industry that is so desperate for what's appropriate. So for any docs who are interested, if you go to my website, you can become a partner. You can see where it says order orthotics. Click that, you will become a partner. And what that allows you to do is you get a code. If you have Joe Smith comes in, your patient, he wears size 10.5 shoes. You go online, put your information in with 10.5 men, put the code in, hit the button. You'll have the orthotics within 2 days with full instructions of how to fit them in the shoe and how to get that individual x-ray. And you will charge the patient their price. We charge you your price. And it's a very, very simple, efficient system of how to start getting high quality orthotics in your patient's shoes at a dramatically reduced cost. So there is the website, drtimmags.com. This brings to a conclusion my part, but in closing, I want to just talk a bit about ChiroTouch because my office, it's taken me 47 years to get it here, but we have a very hot knife through butter system. When a patient comes in, we have protocols and it just works beautifully. And we just have happy patients. We're very efficient. We do good clinically. I mean, it's just a wonderful experience to be there. But behind the curtain, we have ChiroTouch, and I cannot tell you enough what that has done for our practice. So on the left, you can see your menu of selections, and I'm on this program, I've got to say, 100 times a day because you can access it from any computer, but you can get information on patients. You can see who's coming in. At the bottom there, for example, CT Engage. That allows you to send newsletters out, send videos out, send anything out that you want to your database on the tap of a button. Here along the top, you'll see along the top, we have overview clinical documents. What I love is I have all of my x-rays in they're cloud-based. So I can access x-rays and look at a patient's x-rays, look at documents which will have his exam form and his history on it, look at insurance to see what coverage they have. And I have everything at my fingertips so that I am prepared to go in that room with a patient I haven't seen in the last year. Here you can see when it comes to diagnosis, you get to create all your hot buttons, and you get to then, if you look kind of in the middle where it has my name and has the MVP, Aetna, Cigna, you can have a scroll down of all the insurance companies you work with, and all of them pay differently. All of them have different codes that they accept. You bring that up, and now you hit the hot button for treatment that is appropriate for that patient. Hit the button. Now the front desk has that information. The billing department has that information, and you've done a great job. So I can't emphasize enough how thrilled I am with ChiroTouch, because they've given the back end of my office what I feel is a comparable partnership with the high quality that the front office, the clinical side of our practice has. So that's all I have. And for anyone who is still listening, I thank you much, because it's very therapeutic for me to be able to tell my story.
Awesome. Thank you so much, Dr. Maggs. Thank you for sharing just all of your experience here. I feel like what you shared, especially about what you experienced with that patient really not progressing in the way that you had anticipated. And then you said, okay, let's stop, revisit the drawing board, figure this out, was really impactful. So thank you so much for sharing your story there. Just a couple quick questions we have here. First one, beyond professional sports, what other patient populations have seen significant benefits of this program? So are there any other audiences that can, kind of find relief through this?
Well, Sawyer, that's a tremendous question, because I'll have patients ask me, do you treat people who aren't athletes? And the answer is absolutely. What I tell them, my response to them is, the toughest sport out there is the sport of life. To be able to survive in our world with the physicality, the emotions of it. So it applies to anyone living. That's who it applies to. It applies to people who are in wheelchairs, because if you think of the upper half of their body is still an architectural structure that's going to be affected by joints that are fixated, imbalance in weight distribution, repetitive activity. So the answer is, it totally applies to every human.
All righty. What kind of training or certification is required for chiropractors who want to implement this model?
Well, we've tried a variety of things over the years. We've tried different certification programs. We've tried just providing information to docs. And where I'm at now, I'm not out on the lecture circuit, which I was for 20 years. So I've gotten away from that a little. But I would say any doc who has any interest in incorporating any part of this program should contact me. And I'm going to start a seminar series soon, and a lot more marketing. I'm probably going to be putting together a new certification program, just so that we can talk about every aspect of it and provide the training. But I would say any doc interested, contact me and let me individually find out where they're at and see what I can get them immediately to get them able to start up. Because I said, it's taken me 47 years to find out what doesn't work, to go into a very, very complicated industry with insurance pay, with confused patients, with, a lot of misunderstanding out there. And it took me a lot of years to create this program. I'd hate for anybody else to have to learn it on their own. So I'm out to help anybody that has an interest in, kind of bringing this back to their community.
Awesome. Another question here, and I think we kind of touched on this, but could you just give us another overview? So what is the process like when ordering orthotics for patients?
Well, we've really simplified that down, because the first step would be the doctor would go online and just sign up. And there's nothing required. Sign up and you get your individual code. And then when a patient comes in, they order based on the size of the patient's shoes, and the doctor will go online like they would with Amazon. I compare it to Amazon. Go online, put in your information, put the code in, tell us what size, male or female. And our system is so efficient that when you order, you will have the product in 2 days.
Awesome. Super easy. And last question we have here. What are some practical tips for effectively communicating the benefits of orthotics to patients?
Well, I would use my 5th research study and print it out and use it as much as you want to prove that everyone has collapse of the feet. And that's where all of these issues start. Because you've got many out there selling orthotics. I don't know if Good Feet Store is national, but we have a lot of marketing here. And, but everything is with regard to your feet. No one has done the correlation of the effect of collapsed feet on the knees and the hips and the back. Nobody's done the research and data collection that we have to show that it all starts at the feet. So that's why once you own it in your soul, I easily tell parents that 7 years old is when we start with orthotics. No one has ever talked about the preservation of the human structure. We are all symptom oriented, but the preservation of the human structure, and that's a hard concept for the public to grasp. But once the doc starts talking about it more and more and more, every human has collapse of the feet. I have posters available on my website showing the biomechanically imbalanced structures. Docs can download that and just have that poster hanging in your hang one in every room so people can see it all starts at the feet. You have to address the feet.
Awesome. All righty. And I think that concludes the questions we have here. Dr. Maggs, I really can't thank you enough for taking the time today to meet with all the docs. And docs, thank you all for, carving out the time out of your very busy schedules to be on with us. Of course, we totally appreciate it. For those who'd like to be connected with Dr. Maggs, we'll make sure to get you all connected there. Thank you all again for taking the time, and we hope to see you on our next webinar. Thank you so much.
Thank you, Sawyer. Thank you, everyone at ChiroTouch.